Hi, everyone. I'm happy to welcome you all for the second edition of the webinar series as part of the IARC at 60 anniversary. We're very glad to welcome today a few of our IARC scientists as well as some collaborators that are going to be with us and will explain us more about prevention, which will be the main topic of today's webinar. So we have the chance today to have with us two of our well-known IARC scientists, Dr. Joaquim Schuz, as well as Dr. Partha Basu, the head of, Dr. Partha Basu, head of the Early Detection, Prevention and Infection branch for IARC, as well as Dr. Joaquim Schuz, head of the Environment and Lifestyle Epidemiology branch for IARC. We have the chance as well today to have two of our closest collaborators with us, the Professor Hajo Zeeb, Professor of Epidemiology of the University of Bremen and head of Department of Prevention and Evaluation of Leibnitz Institute for Prevention, Research and Epidemiology, and Professor Richard Sullivan, which is Professor of Cancer and Global Health for the King's College in London. So all of them will actually being able to present you the latest scientific evidence that we have when it comes to prevention, which is, as you know, one of the main mandates of IARC as the International Agency for Research on Cancer. I want to stress the fact that this webinar is actually part of a series of webinars that IARC is organizing as part of its IARC at 60 celebration. As you may know, IARC was actually created 60 years back on May 1965 with two main objectives, the idea of fostering international collaboration when it comes to cancer research. And we have today, the panel that we have today is actually representing best this idea of international collaboration and the idea of being able to really foster that international collaboration so we can understand better what actually works best when it comes to prevention intervention to actually fight against cancer. And without further ado, I will actually give the floor to Dr. Joaquim Schuz for the first part of the webinar.
Okay, thank you very much, Clément, for the introduction. Welcome everyone to this webinar that we all hope you find interesting. Let me quickly remind you about the title. It's Fighting the Global Cancer Epidemic Through Prevention, Ensuring Equity and Access for All. So this will be a focus of our four presentations. And I'm starting looking here at the primary prevention work at the agency, but of course in our worldwide collaborations that we are having at the agency. And I first want to link this presentation to the first webinar that we had, which was mainly on the global cancer burden, reminding you that at the moment 10 million people die from cancer every year, and we project that this number will almost double, will increase to 80.5 million cancer deaths in 2050. So overall, this is an increase by 85%. Well, actually, the reason for this increase is good news and bad news at the same time, because it's mainly due to demographic changes with people getting older and cancer being a disease that is more common among older people than among younger people. So it's the good news that people live longer. But of course, it's the bad news that then cancer becomes more commonly a cause of death. And of course, we don't want people to live longer only to get cancer and then die from cancer. And you see already here that we face the first social inequalities because the greatest increases in cancer deaths are predicted for the low and middle income countries, where you see the right part of this bar being much bigger than for instance, in Europe, where it's 36% as compared to Asia, almost 100%, or Africa, almost 150%. So what can we do to prevent cancer? And we have made the best estimates of what are modifiable risk factors that we know and what would be the impact for reducing the cancer burden for Europe. So this is the example of the United Nations definition of Europe with its 48 countries, where we have a cancer burden at the moment of 4.5 5 million new cancer cases every year, expected to increase by 25%, so that Europe has to face 100 million new cancer patients over the next 20 to 25 years. And we know that treatment alone is not an option for tackling this cancer burden. We have identified modifiable risk factors for possibly preventing 40 to 50% of these cancers. And I'm saying possibly because, well, as you can see from this list of causes of cancer, we know many of these factors for a long time, but apparently the implementation of the respective prevention is lacking behind. And this applies especially to tobacco, that still explains half of the avoidable cancer death and cancers in Europe 60, 70 years after smoking has been established as the cause of cancer. So that's surely not something to be proud of. When we look at these numbers, we always have to do it in two ways, which is on the left side. This is exactly the same data, but just presented in two different ways. It's the lung cancer incidence in the Nordic countries, which are the countries with the longest history of complete cancer registration. When we look at the development of cancer over time, we always have to do it in two ways. On the left-hand side, this is taking into account the aging of the population and pretends that the age distribution in the population would be stable, so that we see how the risk factors of a certain cancer, impact the incidence of cancer over time. And here we see that the highest risk of lung cancer in the male population in Europe was in the mid-1980s and then declining. Unfortunately, in women, we always saw an increase in lung cancer risk. But when we want to look at the absolute number of lung cancers from this risk, then we have to multiply the risk of the cancer in the population with the size of the population at risk. And then you see actually that in 2020, we have the highest number of tobacco-related cancers in Europe ever. So that was not during the time when everybody was smoking in the 1960s or 1970s. It is today as a consequence of this population at risk increasing so much that it does not even compensate the beneficial effects that we see from the prevention that we have implemented so far, where we do see a reduction in smoking, at least in men. So primary cancer prevention is something that happens over decades. You're not getting very visible, fast successes. And this is why it has to be implemented now, because it is really an investment for the future generations. And you don't want to feel sorry when we see that in 30, 40 years from now, we still have an increase in the cancer incidence. And here's an example of mesothelioma, which is a pleural cancer, which has mainly one risk factor, and this is asbestos. And this is the cancer mortality from mesothelioma in Germany, where the use of asbestos was banned in the early 1990s. And you can see that even up to 2020, the number of deaths from mesothelioma was still going up 30 years after the banning of this exposure. And this is always something that we have to keep in mind. It's the future investment, and the people that are developing cancer now, these are the people where we have to look at their past exposures. So cancer being very common, starting from the age of 55, 60, 65. So I'm belonging to this generation. So when I look at the exposures that really are the ones that are causing the cancers of today, then I have to remind myself, well, how was the situation when I grew up? And this was that everybody was smoking. There was smoking in the trains, there was smoking in the planes, there was smoking in the restaurants. The teachers were smoking at school. I remember the first McDonald's opened in my hometown when I was 14. And of course, it made it more difficult for my mother when she was cooking vegetables, because my brother and I just had to cross the street and have a nice Coca-Cola and a burger. Everybody was telling you when you got a sunburn, oh, well, this is good for you, because then you just peel the red skin off and then comes a nice new skin out under this burnt skin. And that is the one that gives you a nice suntan. And of course, in our garden sheds, everybody had this, ceilings that were full of asbestos fibers. So when we do prevention today, we do it for future generations, and we have to do it now. So IARC is very much working on tackling these inequalities worldwide. And one of these examples is breast cancer, which is the commonest cancers in Africa. And we did the large-scale African breast cancer disparities and outcome studies in 5 sub-Saharan African countries, seeing a very poor survival of a disease that has a very high cure rate in high-income countries. So this is how Africa breast cancer survival would look like if they had the same survival as we observe in Europe. And this is how the Black African women currently do after breast cancer. So you see the number of them dying within 5 years after diagnosis, clearly more than 50%. The little bit of variety across countries is so much higher. And this study identified the determinants of how you can improve the implementation of prevention, which reaches for all the journey of the disease from primary prevention to secondary prevention to treatment, was leading to this WHO Global Breast Cancer Initiative with the 3 pillars of improving early detection, making sure there's a timely diagnosis, and for the treatment and management to decrease the survival gap that we see for breast cancer. And this is only one of the examples from Africa. We see also this effect that we have maternal orphans due to cancer every year that are also very unequally divided across the world. So this is a world map where the number of orphans determines the size of the continent in this picture. And you see that children growing up without their mother, and we are doing the same estimates for the fathers at the moment, are overrepresented again in Africa and also in many of the Asian countries. Sometimes there's also smaller susceptible populations that are really neglected by cancer prevention so far, which is people with albinism in Africa, where again, there's a very high death rate from a cancer, namely squamous cell skin carcinoma, where we practically have no death in high-income countries. And I could continue to talk about this list further with the high environmental pollution of the Niger Delta, with environmental contaminants level that are up to 1,000-fold higher than we see in other countries, or also childhood leukemia as another disease where we have cure rates of 90% in Europe and less than 20% in sub-Saharan Africa. Radiation-related cancer is also affecting usually the disadvantaged populations much more. And still at IARC, we are working on the aftermath from nuclear accidents and from the time periods of nuclear testing, like the Chernobyl disaster or the Semipalatinsk nuclear test site in Kazakhstan. And there's still a lot of open questions of how these contamination with radioactive isotopes affects the population, perhaps even over generations, because there's still very limited evidence on transgenerational effects of exposure to the parents and probably effects in their children or even in their grandchildren. So thyroid cancer is one of the outcomes that has been clearly related to this nuclear accidents, but also hematological disease, for example, in the cleanup workers. And there's even less data on the general populations because these studies have never been done, because it's usually more difficult to find funding for studies in the disadvantaged populations. And also the occupational cancer, we see the same picture. So here it's also affecting the blue-collar workers in a much more serious way than white-collar workers. So this is data from European studies where we look at the effect on lung cancer for the occupational exposure alone. So this is asbestos here in the upper figure and silica exposure in the lower figure. You see this would be the smoking effect alone. And you see that the combined effect of the occupational carcinogen with the smoking is much higher than the effects from the 2 carcinogens alone. And this, of course, affects the blue-collar workers in a much more sense, where also the smoking rates are higher and where in socially disadvantaged population, we know that smoking cessation is much more difficult to achieve. So what are we trying to do this? We are also trying to, translate all this knowledge into instruments that can help us in cancer prevention. And the World Code Against Cancer framework is such an instrument that sets a framework for more or less cancer prevention recommendations around the world, but is implemented in regional codes where we have more similarities in the cancer burden, in the common risk factors, and also in the healthcare systems for the implementation also of secondary prevention. So the codes translate the latest science on risk factors and preventive interventions into straightforward recommendations for people and policymakers, providing an authoritative, clear, and up-to-date evidence-based set of recommendations that with all the myths that you're also reading in social media or even sometimes hearing in the general news that is misleading people of what causes cancer and what does not. In Europe, we are already at the 5th edition of the European Code Against Cancer. The first version was launched in the 1980s already. And 2 years ago, we had launched the first Latin America and Caribbean Code Against Cancer. So, and this importance is that we know the awareness of cancer risk factors is not very high in the population. And this is a study that was being done by us and the University of Cambridge in the preparation for the 5th edition of the European Code Against Cancer. A study with 10,000 people in 8 European countries. And we asked them the question whether they can spontaneously list what things they think can increase a person's chance of developing cancer. And you see that from these 10,000 people, only 1 out of 3 came up with smoking spontaneously, only 1 out of 5 with unhealthy diet. And you see that for the other cancer risk factors that are also part of the European Code Against Cancer, it's only a very small fraction of people who can come up with it. And when people were prompted and were asked, do you think this is a factor that can cause cancer? It was only 11% that when prompted correctly could recall all the 16 items that we had provided to them previously in the same interview. So that's a lot of shocking news of how much needs to be done that cancer prevention really lands and leads to behavior change in the population. So as I said, the 5th edition of the European Code of Cancer just recently launched at the European Society of Medical Oncology meeting. So the English version of the code is available on this website with now 14 recommendations to the individual and 14 matching recommendations to the policymakers of how to reduce people's risk of cancer. So to sum up, we think that ideally, with the knowledge we have now, 40% of cancers could be preventable. That means for more than half of the cancers, we don't know the causes, meaning that etiological cancer research is not at the end, but research into causes of cancer remains a high priority, but much more implementation research is needed if you see how little awareness on cancer prevention we find in the general population. And IARC is particularly committed to fight cancer resulting from inequalities, inequities, or from disrespect for human life. And regrettably, with the work in our branch, we see that many environment and lifestyle-related factors fall exactly into this category. The World Code Against Cancer framework is a good instrument to improve cancer prevention, and this needs sustainable governments and regular updating. This needs the implementation research for better dissemination and really turning cancer prevention into an access. And there's many other regions of the world where we are at the very first stage at the moment to develop these regional codes. And that's all what I wanted to say about primary cancer prevention. And we leave all the questions to the end. So if you have questions about this talk and all the following talks, please write them in the chat, and then we can address them at the end. But for the moment, I thank you for your attention, and I directly hand over to our next speaker, Professor Hajo.
Yes, thank you, Joachim. And I'm greeting you from a country which has a very bad record in terms of some of these things, particularly tobacco control. We are not at all very good. So this is Germany, and I'm just sharing now my screen here, going onto the full display. What I'm talking about now is the question that many of us come across. How about the digitalization in all this, in prevention? I'll touch a little bit on AI, which is also coming up, certainly also for prevention. So I'll try to take you a little bit through, digital ways forward in this field. Just to kind of frame this, I mean, you've all heard of digital health, maybe, and we are promoting now also digital public health, and you would see how we take it. It's e-health and m-health. E-health is everything that is on web pages and so forth. M-health, our mobile applications, and digital public health would be more towards issues that really tackle the population level. So everything that perhaps supports screening programs, maybe that gives contextual information, certainly also looking towards these preventive issues that we just discussed now, or that we put into digital public health. It's all in a bigger framework of digital health, but I mean, digital health also includes things like, health information systems in hospitals and all these things, and maybe the prevention and public health part is less aligned or less into these topics. So what is interesting in digital cancer prevention? There's the idea of having very efficient data provision for action, and we heard we need to act now. And so the data that, for example, also Joaquim presented, I mean, maybe, and this is the idea with digitalization and things around that, maybe things can be promoted and used much faster. Individual risk assessment is a big issue. That gives information also for the individual, maybe at the fingertip, and it's already partly there. There's a lot in what we talk about in digital cancer prevention about targeted health communication, health promotion and prevention, reminder functions, cancer literacy, cancer education, and we heard about the code. Also, the code is going to be presented, is already presented in digital ways, but there will be more, and I'll talk about this in the second part. And then obviously the idea is also that through digitalization, people can take part in shaping their preventive pathway. More participation, networking for cancer prevention. It's getting a bit easier. It has its risks, and misinformation was already mentioned. It's also out there, so we need to look at this. And why digital? Okay, digital is probably faster than a lot of the analog stuff that we've been used to. And we can target, even in a population approach, things can be targeted because this is what digitalization allows. It's dynamic in some ways because you can adjust it to new things more quickly than having big poster campaigns. You will not print the next day or in 2 weeks later another poster. It will be there for some time, and in digitalization, this allows to be done. Now, it is also scalable from smaller solutions to bigger solutions. In a very short time, you can reach large populations, those that are online, but we know this is now very common. And it can thus be also efficient. We don't know too much about it. The question of health economics and all this is still under discussion, but there's the idea that you can have efficient provision of data and actions. Lots of things out there, and I'll just show a few things. These were pages, videos, podcasts, a lot of devices and tracking tools, etc. A focus strongly on apps, interactive apps ideally, and then now AI-generated tools. I wouldn't put telemedicine necessarily into this, but obviously telemedicine, if used for preventative purposes, also in the overall game here. What I'm not talking too much about is now this large issue of data, because even with digitalization and the advance for prevention, large-scale databases can also be effectively used, especially when they're used not just to identify risk factors, but then also use, for example, contextual data, healthcare data to promote preventive activities, maybe to evaluate preventive activities. So that's also there, and this is really then big data for prevention. As I say, I'm not talking too much about this. I'm going to show you just a few examples of all these things out there. They range from web pages, reminder activities, very nice offers on YouTube and other platforms, things that are presented by prevention institutes, and also individual risk assessments. I go to one of those up here is the prostate cancer risk tool, where you, as a man, even as a woman, if you're interested in your husband's or friend's risks, you can do that and enter certain data to find out, what your 10-year risk of cancer is. And these things have been developed by, high-level scientific consortia. Many of them. There are also some bad ones out there, but so one has to look for quality material out there. And there's also all this in terms of digital coaching, individualized partly, to become smoke-free. This is like a German page that is out there, and there's a lot of these offers now coming on, and again, many of them as apps on your phone. Just one thing that I wanted to point out is we have these risk calculators can be used for individual risk communication. For example, the CanRisk tool, and it's a very well developed tool with a huge model below, basically, and this is for calculating breast and ovarian cancer risk. But here the information is very extensive that is needed, including genetic information, or that can be included at least, and polygenic scores are there and so forth. So these tools are out there. This is not for everybody to use. This is for health professionals to use. But even for health professionals, I think digitalization now offers more and more tools to help them work also as preventive agents, let's say. And I think this is one example. However, this is, as I say, not for the general public to use, but it is a very strong model here. Let's move a bit to apps. The situation here is that there are many different approaches, from educational to symptom tracking apps, lifestyle management, screening and reminder, and then also community apps, support apps for example, also groups that work in cancer prevention or even in cancer care. So, and this, I would like then to move over a little bit, linking up to the project and the activities of the ECAC5 activity. So we were involved in a project that was supporting the development of the mobile app to support the ECAC5. And there was a project called Bumper, and we brought sort of the scientific support for the company that develops or developed this app. And this has been going on in parallel, basically, to the ECAC5 project now. And this is the app, and I'm going to take you a little bit through what we found out and what also the typical way these things need to be developed maybe also represents a little bit. A prerequisite for all of this is something that we need on many sides, but also on the side of the public. This is digital health literacy. And this is a sort of new sub-form of the well-known health literacy, but we have here, this is a newer definition here. We use digital technology to search, acquire, comprehend, appraise, communicate, apply, and also create own health information. This is a bit new and certainly an opportunity in digital health literacy, and also the idea of doing this, using this across the lifespan is also something which is a bit of an extra activity, because we realize digitalization is there, it's going to be with us whether we want or not, and we also, the prevention landscape needs to take in account of this. Obviously, in this field, then also cancer literacy comes in, because that will be then linked to digital health literacy, and that's basically health literacy with a cancer focus. We heard already, we have some insights on this. First question might be, does digital health literacy actually increase through any use of such apps? Yes, and I'll show you a little bit what we found in our Bumper studies. And then what Joaquim already mentioned, does the European population have good knowledge of cancer risk factors? No, they don't, because as we heard, the recall is really, if you are asking, do you have any idea of risk factors, people are on average able only to mention 2, which is, I think, as you said, a bit shocking, but this is then what is empirical data right now. And sometimes in the prevention community, we think people actually know more. And but then if you ask precisely, then it seems like maybe the big players, tobacco comes out, but even not that amongst everybody. And then a few other things do not even feature at all. So the app, I cannot show it to you. It's not ready because it has to be aligned with the ECAC5 contents, which wasn't possible until very recently. Just now it was launched, as you heard. But this is kind of what this app in general will look like. There will be a dashboard. There will be some goal setting. there's a profile, that your own profile basically, and then there will be, its learning goals or learning modules will be in there. So you can work with this, there's gamification in it, and so on and so forth. So in the Bumper project, we looked at this, and especially my group, we looked at it under the question of usability and feasibility. Is this going to work? And also, is it going to be making any sense? And do people actually, take part in such app? And this was part of our work here. We did focus group discussions, a mixed methods usability study, where we had individuals from different countries in Europe, and then there was like task completion, but also digital health literacy was measured there. And then we did a pre-post evaluation after we actually applied the almost ready mobile app, and people used it with a functional beta version, and they used it for a short time, only 7 days. So obviously we'd like to have them in the future to use it much longer, but this was now the time frame we had in this study here. And we asked them, about the system usability and also cancer awareness, whether it was actually changing or increasing or decreasing. Perhaps. No, what we found is that with the usability, the task completion, so people could work with what we had to offer, but the older adults, and that's typical, and we need to take care of this, again, an issue of inequality, faced really greater usability challenges. And there was quite a lot of requests for multilingual support and offline functionality, often an issue that we also encounter in digital health. I cannot rely on the internet. Can we also have offers that are available offline? The usability, there's a standard scale that can be used, and on that scale, unfortunately, we found that the version that was there was really not yet up to standard. Really, it had a relatively low marking grading here, and you see it was 63, 62.5, and the good benchmark is at 68 for this scale. So there was still work to do. But fortunately, we were not yet finished with the development, so things still could be changed. And then the issue of awareness, we had some indication that the cancer awareness was indeed increasing with people using this over the short time, indeed, but still there was some opportunity, and there was an indication that this actually worked a little bit better even amongst people with low digital health literacy. Often this is the sort of lower SES groups, and at least people also with lower education as such. So that was quite good. We had then some ideas about targeting drivers of engagement and equity, really, and taking the socio-ecologic model. You have these different levels, and we have some suggestions or developed suggestions that probably relate to the current app, but also to other apps that will and are being developed in prevention. I mean, you need to have definitely an intuitive interface and age-friendly design. It can't be too small. You have to have things like, good color mixing and so forth. The onboarding, so that people get into this app, needs to be very easy and straight, and literacy needs to be, not the requirements need to be at the level of, early school graders, maybe grade 6 to 8. This is what usually one wants. And again, this we observed in the current app that it was not yet there. And then the AI-powered personalization is really an opportunity that can be done in the future with large language models, for example. The goal setting for interpersonal level, there's issues like rewards and gamification that are often features of this, and other points like I mentioned here, the design and the goal management. These are typical things from psychology that we are now getting into these apps, and also for prevention apps, it's essential, because otherwise these things will not be used for any serious amount of time. At the community level, I mean, these issues I mentioned already, the offline access is a big issue. Can this be localized? Can I, for example, have prevention information about, for example, service providers at my place? That would be very useful, including the cultural targeting, basically. Partnerships are important. For example, the cancer leagues there, the major partners also for the diffusion of this app. And then it needs to be broadly available and interoperable with other offers. And finally, then at the policy and systems level, very much ideas in all digital health technology for prevention or for care. Data security needs to be very transparent, where data are coming from, where they're going. Technical reliability, if things break down all the time, and we had this problem definitely in the development of our app here, it's a critical issue. And then content maintenance, keeping it updated is also very important to regain and keep trust in this kind of activities. So this would be our summary here. 3 pillars to get digital prevention tools, including our bumper app, towards a good level: the usability and technical reliability, advanced personalization, and content and stakeholder alignment. And obviously, we are looking forward to seeing this app coming up very soon as a really good, inclusive, evidence-based platform to support the Europe's Beating Cancer Plan. Just a final look at AI. Many potential applications coming up now. We can't even see right now, what is going to be helpful for us. But one interesting direction, which I had also with Carolina from IARC last week, the opportunity to get to know a bit better, is vibe coding. So what is happening there is that you actually develop digital tools, not by coding, but really by writing reasonable prompts. Very fast. You don't need a coding or programming skills. It's stepwise but fast approach. So after even an hour, you may have some product already. It has many critical aspects, definitely, but also surprising results, because you do see things after a very short time already as a something and an interface that you think, oh, this can be useful for my cancer prevention activity in our case now, and maybe also cancer literacy changes and so forth. So you need content knowledge, you need thorough checks. It can't be more than a first step, but AI is going to change the landscape, I'm quite sure, also for many of these tools that we now developed through long development processes over maybe years at times. This is not going to be the same in the future. Right, so I think in total, I would like to say we have to advance evidence-based digital cancer prevention. I've shown you a few essential steps and things that have been done in the past. And yeah, that's all from me, with congratulations to 60 years of IARC. Thanks to you. Sharing now, and I think it's now Partha's talk, right?
Thank you, Professor Zeeb. Let me share my screen. Hey, good afternoon, good evening, everyone. Most of you are quite well aware that secondary prevention of cancer, which is cancer screening, is one of the most effective means of reducing mortality from certain cancers, provided the services are delivered with quality and within the framework of an organized program. So to understand what do we mean by organized program, what do we mean by quality, first let us look at the evidence of how much effective an organized screening program may be. This is evidence coming from a systematic review, which clearly shows that if cervical cancer screening is delivered through an organized screening program, the reduction in mortality from cervical cancer can be between 40 to 90%. And similar evidence is also there for breast cancer, colorectal cancer, and that is why cancer screening program with organized within an organized framework has been very strongly recommended, especially in the European context. What do we mean by organized screening program? There was quite a lot of confusion before at IARC. We had an expert consultation, and that the experts came out with a set of elements, which we call essential elements of organized screening program. So there has to be a clear governance of the program, which specifies the protocol, the policy framework of the program, and the service delivery has to be appropriate in terms of there has to be a system of inviting the men and women to the screening program, because as you know, screening is essentially for men and women who do not have symptoms. They are apparently healthy. And then there has to be also a system of delivering the results and inviting the positive men or women for further assessment. But you know, among all these different elements, what is quite clear is that the elements that are in deep blue are all related to quality in cancer screening. So quality assurance means that there has to be a defined protocol of implementing quality assurance by a team, and there has to be measurement of the performance of the program on a regular basis to measure certain key performance indicators. I will come to that. Let us take the example of a country like Brazil. Brazil has a breast cancer screening program in which women between 50 to 69 years of age are recommended to undergo mammography screening every 2 years. And because there is a policy of the Brazilian National Health Services, the women can get mammography screening done free of cost. And those women who are detected to have abnormalities on mammography, they are provided free assessment and free treatment. And very interestingly, Brazil has more mammography machines that are needed in the health services. But what is the impact of this investment that has been made in mammography screening? You can see that over the last 20 years or 2 decades, over which this mammography screening program is there has been no reduction in mortality. Rather, the breast cancer mortality in the target age group is gradually going up. So where exactly is the problem? The problem is in quality and organization of the screening program. So quality of screening program, just like any other health program, has certain aspects. First and foremost, it has to be available. There is a huge inequity across the world in terms of screening program availability. That can be cervical cancer screening program, breast cancer screening program, or colorectal cancer screening program. Services are not available in some countries, and even in some countries where the services are available, they are either not accessible because of several barriers, including geographical barriers, and also they may not be affordable. And even if it is affordable, it may not be acceptable to the population. Say, for example, if there is a test which has a lot of complications, it causes a lot of pain, it takes a lot of time, it may not be acceptable to the population. And finally, the services have to be delivered with quality. And if that quality is not there, in spite of a screening program being available, accessible, affordable, and acceptable, will not achieve the required or the expected reduction in mortality from the cancer. So to have a properly organized screening program, the IARC consultation came out with the different elements, and of those elements, the top 5 elements were these: that there has to be a protocol or guideline which very specifically says who should be screened at what interval with what tests. There has to be system for identifying the target population and inviting them to screening. This is what we call population-based screening program. There has been quite a bit of confusion with the definition of organized screening program, opportunistic screening program, population-based screening program. Many people use the word population-based screening program interchangeably with organized screening program, which is not correct. Population-based screening is where there is a system of invitation of the population to screening. But just by being population-based, a screening program may not be well organized. For organized screening program, there has to be performance evaluation with indicators, and for that what is required a health information system that captures the performance of the screening program from invitation to detection of the disease and treatment of the disease. So to highlight the importance of quality and organization, IARC launched the program, the project we call Cancer Screening in 5 continents, CanScreen 5 in short. It has been now identified as IARC flagship program. And this program has certain objectives. Number one is to collect and disseminate information on cancer screening practices, policies across the world so that we can learn from each other. And at the same time, it is a global repository of information. Secondly, the data collection has to be done in such a way that we can measure certain key performance indicators. And these key performance indicators have been defined in a harmonized way so that they are comparable to each other. We know across the world, even the screening coverage is defined in different ways. So many of the times they are not comparable. And number 3, and probably the most important objective of CanScreen 5 is assist the countries to have a health information system that collects data on a regular basis to measure the key performance indicators, which will help them to improve the organization of the screening program. The project that was launched in 2019 has already been expanded to 106 countries across the world. You can see in the map, and then additional 13 countries have provided data, which we are looking at. So maybe within a few months or so, we'll have about 120 countries participating in this global project. So in the CanScreen 5 website, if you look into that, you will get the information on the program organization, program protocol, program policies for breast cancer screening, cervical cancer screening, colorectal cancer screening, and lung cancer screening for the different countries. Obviously, it will depend on what kind of programs the countries have, but then essentially the information on the organization of the screening program in an individual country is presented using such very nice fact sheets. Because of this kind of information collection, we can always get many important information that we can compare across the countries. Say, for example, here I am showing you a map that shows what is the status of data collection across the screening programs across the globe. You can see that there are some countries, but these countries are mostly in the Americas or in Europe, in Australia, that are collecting individual level data from cancer screening programs. Some are collecting aggregate data, which is also important, but then not as good as individual data in terms of program implementation or program monitoring. But if you look at the Africa region, and even in the South Asia region, there are many countries that are not collecting any data at all. As I said before, the CanScreen 5 aims to harmonize the key performance indicators, and that is why with the help of a group of global experts, we have defined a set of core performance indicators. And the way they have been defined, that we have very specifically mentioned what is the numerator, what is the denominator. Say, for example, detection rate. The numerator is number of individuals with pathologically proven precancer and cancer detected. Denominator is the number of individuals screened. So we can estimate the detection rate in the same harmonized way. And that helps us to compare the results through such nice bar graphs or graphics. Say, for example, here I am showing you across the different European countries what is the detection rate of breast cancer. And you can very clearly see that there is quite a bit of variability. Now, the important thing is that as a program manager, we need to look at this variability and try to understand the reason. Say, for example, Denmark has high breast cancer detection rate, much higher than Cyprus. Does it mean that the mammographies are not being properly read? Does it mean that the women who are positive, they are not undergoing proper assessment? Or it may be just because the incidence of breast cancer in the Cyprus is less than the incidence of breast cancer in Denmark. So there can be several reasons for this difference in data. But as a program manager, one has to look into in depth of the data and try to understand where are the gaps in the program that can be improved. So CanScreen 5 has a very strong component of building capacity in the cancer screening programs to understand the data and make decisions based on the data. So it has a hybrid training program. There is a self-paced learning that highlights the principles of cancer screening, how to plan and implement a good cancer screening program, and most importantly, how to do quality assurance of a cancer screening program. And after the online training, so you can see that this online training has been already accessed by more than 1,500 users across 184 countries. But this online training is followed up with a data-driven workshop in which the cancer screening program managers are brought together and they try to identify the potential gaps in the organization of cancer screening in their own countries based on the data and information that they have collected. And jointly, they decide how best to improve the quality of cancer screening programs. So the outcomes of CanScreen 5 is that we are developing the future leaders who will guide cancer screening policies, organizations in their own countries, and the screening programs will have the greater impact. And in the process, we are developing a CanScreen 5 community of experts who are interchanging information across each other's country. So the final message that CanScreen 5 wants to give is that quality is at the core. When we collect data, that is just the beginning. When we organize the data to estimate the key performance indicator, that is what we do, what we know as quality control, but that is not enough. From the data, we need to understand where are the gaps, even where are the strengths, so that the cancer screening program can be improved. And based on that, when we take action, that is the ultimate goal of quality improvement, which will lead to the ultimate impact of cancer screening programs in terms of reduction of cancer mortality. Thank you very much for your patient listening. So I'll stop share and over to you, Richard.
Surgeon getting himself off unmute there. Good. Can you hear me loud and clear?
Yes, Richard.
Good. Thank you very much. Real pleasure to be with you all here today. And now, as they say, that something completely different. I was asked to give the rather grand title talking about the political and economic determinants of prevention, which is a rather grand sweeping topic. It really comes out of a lot of work we've been doing over the last decade around the political economy of health, welfare, and cancer specifically. But I'll also draw a few of the messages from an ongoing piece of work for the World Bank Group. We're writing their cancer strategy at the moment. And I think there's been some interesting reflections which will tie back into what Partha and Hajo and others have talked about today. Let me just foreground the problem set from a political economy perspective. We really are in a new world order for health systems financing. The US withdrawal from multilateralism has had massive impact on overseas development assistance, also on health assistance generally. It's also, of course, triggered massive revisions in what other high-income countries are spending as part of their overseas development assistance. Essentially, what we're seeing is a move into the militarization of our financial budgets at the moment and renationalization. We've also, of course, got a new America Global America First Global Health Strategy. And that is also bringing, I think, some interesting challenges to how we think about prevention and more broadly health systems in the future. But it's not, strangely, all bad news. There's no doubt that the economies have become very aid dependent. And as Mohamed Partha said, the Nigerian health minister recently, we're on our own. It's got a lot of countries waking up to realizing that domestic resource mobilization is going to be as important as overseas development assistance and health assistance. But I think when we think about prevention, and it's prevention within in the welfare and health space, health does find itself stuck at the moment between a rock and a hard place. By any measure, the world is becoming more unequal. Essentially, what Thomas Piketty said is coming true. We now see something like 70%, 76% of the wealth, 52% of the income now concentrated in 10% of the population. And some countries are much worse than others. The other issue on the other side is just the general cost of welfare and health services. None of the technologies we develop for cancer or indeed for health services really improve the productivity. And whilst digital transformations and AI may improve productivity in the future, as it stands now, the cost of delivering healthcare will continue to increase. And within this overall welfare and health budget, of course, prevention sits. For many countries looking at what to fund at the moment, of course, their big problem is the debt trap. Debt traps have worsened despite relief 20 years ago, and especially for particular regions like sub-Saharan Africa. But it's not just the level of debt, and you can see here the comparison between 2008 and 2022 for the 52 African nations, incredible increase in debt. It's also the complexity of the debt that's out there. There are more debt holders, particularly bond holders, private creditors. China's moved in very heavily, and that means debt relief and negotiating debt relief is much harder. And as I'll talk about in a moment, that does have implications. Now, one of the most important implications, of course, is around debt servicing. And this remarkable piece of work is, a few years old now. It was done by Victoria Fand and colleagues at the Centre for Global Development. But what I want to do is just get you to see that yellow line at the top there. Even before the COVID-19 pandemic, the debt as a percentage of GDP was worsening for the bottom 72 countries. When you look at external health financing, domestic government health expenditure, those are the bottom two lines. You can hardly see. They've hardly moved at all. And just above those is a grey line, which is essentially interest payments as a percentage of revenues. And those are increasing. So what you're seeing is at an individual country level, the space to put money in education, to put money into health, and generally then onwards into prevention is starting to contract. And of course, many countries have much more acute problems. Nearly every piece of analysis that's been done looking at global health financing, whether it's World Bank, OECD, this publication, The Lancet, indicating that healthcare spending per capita is decreasing. And that includes anything to do with prevention as well. And that contraction is set to continue over the next decade. So unless you're in that very lucky dark blue category, the rest of the countries are either in trouble or in serious trouble. And it's not just this. I mentioned earlier about obviously the US withdrawal from multilateral funding and moving into an America First strategy. It's a little bit more than that. When you look at the political environment around the world and you look at the general financing, what you're seeing is, as President Macron talked about recently, he called it le crunch. Essentially, the economic and fiscal headroom is contracting. Firstly, because of political changes. A lot of countries now are becoming much more nationalistic in their politics. And then secondly, because there is an enormous rush for what money exists out there in the overseas development assistance and health expenditure. And there are loads of new funds chasing the same money. So we have a climate change fund, we have a pandemic fund, we have antimicrobial resistant funds. These are all new on top of the replenishments for things like IDA, for example. So all these pledging coming up, there's just a lot more people chasing a lot less money. So when you're looking at the political economy of prevention, and I would include even early detection into this, and this is something that we talked quite a lot about in this commission that came out a couple of weeks ago, the human crisis in cancer. prevention still, as a topic, and that includes prevention overall, not just in cancer, is still politically deprioritized. Cancer medicines, remarkably, absolutely dominate political and financing narratives in cancer, and they dominate it above everything else. And below that, you have radiotherapy, a massive drop to things like surgery, palliative care, and prevention still comes roughly at the end here. And of course, at the same time as those sort of what I would call supranational narratives politically are changing, what we're seeing at national level in many countries is environments which are not conducive to long-term prevention planning here. We're seeing a lot of political short-termism. By that we mean rapid change in the political parties in charge of countries, and also increasingly, amazingly, siloing. So the importance of having a pan-government approach is essential, but when you actually look at the political science analysis of many countries, we're seeing worse siloing going on here. All of these, of course, are kind of drivers against moving the prevention agenda forward that you've heard about today. And then there are wider determinants to consider. A move to bilateral trade deal, of course, doesn't bring in the WTO protection that you will get. And this is again being driven by China and by the USA. Other countries are following suit. We're seeing increasing conflict and fragility, and work we've done for Lebanon, Turkey, doesn't matter where, looking at the political economy of health, shows the first thing that gets eroded is, of course, prevention and public health. And it takes a long time for those elements to come back into the system. And then it's interesting, we've also known that, development has been also eroding for quite a while. But at the back of all this is something called isomorphic mimicry going on. And what this means is, it's a term many of you won't have heard of, is that when you look at individual governments, you'll see them essentially pretending to adopt formal structures and giving the outward appearance of functionality without actually doing it. It's essentially weak states trying to mimic stronger, more developed states. This is what we call the technology of failure. So they may be essentially pretending to do prevention or public health, but then when you look behind the curtain, when you look at what's actually going on, you find they're not doing this at all. And this problem of isomorphic mimicry is really, really prevalent now in health and development generally. And we're seeing, and I haven't got time to show you today, indicators of this going up and up and up and up. And there are lots of other issues like load bearing, etc., on welfare and health systems. Okay, so that's the good news. What about some solutions? So the role of major funders in the future health, the jury is still out for the Western high-income countries. We're not seeing any indication from the new administration in the USA that prevention is on the agenda. America First essentially means putting companies and tech companies into bilateral trade agreements with individual countries in sub-Saharan Africa and Latin America. And we've seen no sign that prevention and public health is in that. China's an interesting one. There is little doubt that China is radically expanding its global health and development footprint. You can see and read the words on this slide here. It is a massive, massive donor now. Some of that money, though, is still very much in the kind of what we consider to be the Western model in terms of profit seeking. But the reality is now that it is now a major donor to many of the poorest countries we're talking about in the world. And it holds, what, 21% of the debt, but also is giving a lot more. I think the issue for us is what's going to happen beyond the Belt and Road Initiative. That has been the kind of backbone for the health and development for China. They're definitely moving into other areas for funding. If you read, as we do, a lot about Chinese intentions, public health, prevention is now starting to appear in a lot of the external communiques. And this is probably partly, it's about de-risking their whole Belt and Road Initiative, which is mainly about infrastructure, but it has a lot of health infrastructure in that as well. But it's also maybe about a wider global public good. And the question I think on everyone's mind at the moment is where is China going to go in this sort of funding? It could just simply ape the West, focus on cancer medicines, high tech, vaccine technologies, etc., and not give funding for global health and prevention. But the interesting indications are that China is a provider of global public goods. looks like it's potentially going down that route, and some work that myself and Lewis Hussein did and published in the Centre for Global Development. If you're interested, read that op-ed, because it lays it out in cold detail about the various options and why we think at the moment that China is heading into developing more global public goods, which will mean more money going into prevention. Where might the World Bank cancer strategy fit? I have to be a little bit careful here because I don't want to kind of spoil all the excitement and the fun when this all comes out. There's going to be, I think, a link to financing to a country's actual state of transition. So in other words, much more focused plans. This idea of comprehensiveness for national cancer plans makes no sense. Everyone talks about cancer in LMICs. It's meaningless. You're putting Chad and China into the same group there. This means making financing of plans much more rational. It also means integrating prevention and the needs for prevention, not just into primary health care, but into health system strengthening and connecting it to downstream services. Partha talked about mammography and services and connecting those. We see time and time again money being put into screening of some sort, into early detection of breast cancer, and then you look downstream and there's no surgery, no radiotherapy, no basic 101 chemotherapy, or if it is being provided, it's of poor quality. And that simply is a failure. So it's this end-to-end pathway. New approaches to enablers. There's going to be quite a lot of discussion around digital transformation. To be blunt, we're a little bit cool about this. We see great potential, but there are huge digital deserts throughout the world, and digital transformation and AI can drive inequalities as much as it can become an enabler. And then finally, developing new financing mechanisms. The classic mechanisms of IDA funding, which is sort of zero interest grants for poor countries, and then more concessional funding, I think will get more nuanced. There's going to have to be a lot more nuancing around cancer funding, particularly using third parties. And also, how then do you sustain different domains of the overall cancer system and health system? And finally, to say, I think, when you're looking at the global health, the general sort of global health initiatives, narratives, again, it goes back to the beginning. Prevention is still very weak in comparison to classical global health actions. And I would argue so is cancer, frankly. It's just a dot still in this. NCDs are still framed within primary health care, which is essentially community delivery of basic 101 NCD medicines. It really isn't seen as hospital-based services and isn't connected back into the community. And I think there's going to be a clear need to link, as I said before, the prevention to the right implementation strategies, including the money. So we're very good at doing implementation work. What we're really lousy at doing is then turning that into reality by having the right sort of economic models and the right sort of financing. So in crisis, there's opportunity. The neoliberal agenda in health is dead. Do feel free to contradict me if you wish to. There's a new form of health realism now. International financing will dramatically change, and there will be more demand for domestic resource mobilization. And I don't think we're going to go back to the days of where money was just given over and individuals and countries were not held to account. The prevention agenda, of course, being a core government responsibility. I think at the moment, those governments evolving and considering their current healthcare expenditure crisis and other forms of crisis, this is going to be a major tension. And I think it requires diligence and really forward action in both the political, economic, and diplomatic spaces to keep prevention there, because this is a very easy area for countries to get rid of or pretend they're doing when they're actually not doing. So thank you all very much indeed, particularly my collaborators, and a very warm thank you to Partha Basu. Been working with this Access Cancer Care India for a while now. It's been an absolute joy. And also to my colleagues back at the ICP, particularly Ajay Agarwal, Julie Terode, and rest of the colleagues. And thank you to IARC again for inviting me.
Okay, thank you so much, Richard. And we have a little bit of time for questions, so it's not too late to write your question either in the chat or in the Q&A. We have a few, and while some of you may be typing, we can probably start addressing those, because there's one question about policies and the regulations on passive smoking, which I think is a brilliant question, because well, it's a good example to illustrate the struggles that we sometimes face, because I mean there is indeed policies, let's call them in writing, but the way they have been implemented in the European countries is well, let's say suboptimal everywhere, I would say, but in some places even more so than in others, and sometimes because health policy is in some of the larger countries even the responsibility of regional governments and not even the federal government. You can have different regulations even within a country. Putting Germany maybe again in the spotlight, where for instance the indoor smoking is indeed prohibited by law, but then areas in restaurants that are like a tent shape in one German region are just declared as outdoors, which is a very creative way, and I wish sometimes the governments would be as creative for other challenges that they are having. But here it really shows one of the inequalities really in implementation in Europe, where we see, for instance, Sweden's one of the countries that really forefront restricting even the outdoor smoking to areas where it's possible, and in other areas it's not. And in particular, Eastern Europe, unfortunately, is very much behind in still having the highest smoking prevalences in all over Europe. So this shows that actually policy, cancer prevention policy, it's not only the it's not only the legislative act, but it's then what comes out of it for the implementation. And a second question that I've seen is actually on in the implementation of cancer prevention, how can countries work together and learn from each other? And that is really very good, because I mean in our webinars the focus is almost the academic collaboration, as you can see. But in cancer prevention, there's also, for instance, the cancer leagues in most European countries. And they are, of course, the ones being very close to the communities and trying out different approaches in their campaigns. And, some countries are focusing on other topics than others. And, these kind of meetings are really ways of learning more from each other. Because we have estimated that actually a good fraction of cancers in Europe could be avoided if every country would copy the prevention measures in place from the best in class. Because there's not best in class for everything, but there's a best in class for every topic, and if you would combine all these, that would be a major step forward. Okay, now I see one question here popping up that I think is for Richard, for the cancer control financing. So do we need to consider routine interventions which can be implemented when we talk about the cancer control financing? So yes.
That's a great question. I think at the moment, there's a lot of, how can I put it, robust discussion around this. There is, and I just want to separate these two things out. There is this discussion around financing prevention per se for a country as a public good that umbrellas the entire country's ecosystem. So that's one element. And then there are elements, as Partha was saying, the screening, for example, that fit very much within a disease-specific funding approach. Where we're having the complexity on the latter, of course, is that cancer reflects all the strengths and weaknesses of health systems generally. So when we're talking about the specificities of setting up a cancer screening program, you're also having to deal with the financing of downstream elements which come up from what we would consider to be generic service delivery. Okay, so general medicine, general surgery, and then built on top of that. And so we are increasingly now getting to the point saying, look, and I think this is where we're going here, is saying, look, we're not giving just countries just, screening and or early detection money to strengthen. We want the whole pathway. And that whole pathway is a way of changing the dial, as Partha was pointing out in his excellent diagram, of putting money in and then saying no change because part of that downstream pathway hasn't improved. But I think those two things are going to get separated, and I think rightly so, because at the moment there's too much leakage, and there's a word in economics we call fungibility, and that's code for, well, we've got money over there, we can borrow and we can put it somewhere else, and we're not keeping the money in that particular area, and then we're wondering why we're putting money into public health and we're not seeing any changes. And I think there's going to be a bit more ruthlessness where that's concerned. That's my sense of where we're going.
Okay, thank you, Richard. There's one very good question, actually, what the scientific community can do to put cancer prevention on the policy table. And that's maybe such a good question that we, all four of us can maybe share their opinion about this. Maybe Hajo, you want to start?
No, I can start and just say, unfortunately, Richard is very true in the sense that, the discussion space is not really increasing, but in some countries it is, mainly also because of sometimes economic and financial reasons. Just simply seeing with this growth in treatment costs, we're not going to get anywhere soon. We have to find other ways, and that is really a strong call then to at least look at prevention. Prevention is not necessarily a lot cheaper, but it puts money elsewhere. It also increases quality of life, hopefully, for many people. So we have to be a bit careful and also learn very much about, the costs of prevention, the true costs, because sometimes there's the reflex amongst politicians that they say, oh, I like prevention because it's going to be so cheap. But it's not necessarily so, but we have to be honest about it. And really, there are definitely some savings involved, and they need to be sketched out very clearly. I think that's important. And then we need exactly this kind of knowledge, about all the risk and the preventability, as you mentioned, and then cost information to really get into contact and speak with the politicians. And I think it's a call for the, let's say, public health community at large to get going there. And obviously this is well beyond cancer, but cancer is such a, especially in our societies in the high income countries, such a major player that it's really there. We do have a strong entry point for this discussion, I would say. But also the other countries, the NCDs are now becoming so important everywhere in the world, and cancer, you mentioned it, in African countries. So again, they're even worse off sometimes in terms of getting to work with their politicians. So that's then where the global health community needs to step in and really say, look, we need to do this together and be as strong as possible and use all the fora that are there, including, unlikely ones, perhaps like the COP or whatever, to bring it to all places where this can be discussed. And that's not where we are yet, very strong, I would say.
Thanks, Hajo. Partha?
I'll address the next question specifically. What do we do about, addressing the myths and misconceptions? Communication is one of the most important aspects of organized cancer screening program. But then the thing is that communication, or the mode of communication, the messages that go out, it cannot be same across the countries or even within a country across the different settings. So it has to be tailored to the local context. And also, as Richard used this very interesting word, isomorphic mimicry, which is like following what Finland is doing. So because Finland is sending an invitation letter to everybody's home, we'll also have to do it. It does not work. So countries have now actually found out their own way of communicating. Say, for example, let me take the example of Morocco. Morocco has a large breast cancer screening program. It is opportunistic. But then what they have done is they have created the facilities. That means all the primary health centers, they have trained doctors who can do clinical breast examination. They have created facilities for diagnostic evaluation. And so once the facilities are created, now they go for campaign mode. That means in the month of October, there is a very highly visible campaign where all the different advocates, they come out, including the top political leaders, and talk about breast cancer screening. And we have actually measured that during that month of October and subsequent 2 months, there is a huge increase in breast cancer screening. And then it fizzles out. But by doing that, they managed to have more than 60% coverage with breast cancer screening. So the point here is we cannot have a fits all solution for all this. We need to look into our own capacity, our own need, our own context, and then make decisions. And then I have also in the chat, we have, I have just put the link to a document that we created on the framework of cancer audit, also framework of communication in cancer screening. Those who are interested may have a look at that. Thank you.
Okay, thank you, Partha. And combining the two questions, I mean, informing policy and addressing myth was a good response because they are closely linked. But Richard, since you also have so much experience talking to policymakers, what do you think we can do better as the scientific community?
I think there's probably three things to point out. I'm still bitterly disappointed by the inability to get prevention and public health into the kind of comprehensive cancer center narrative in the kind of meso level. So a huge amount of power and authority rests in those center directors, the way we judge those centers in Europe and around the world. And apart from, a couple of handfuls of center where their directors are really pushing prevention and public health, a part of their comprehensiveness, it's absent. So that's one problem. And that's tied, I guess, to the funding agencies, both federal and philanthropic. I think by any measure, whether it's bibliometric, whether it's the ICRP database of money going into the system, there's again a lot of isomorphic mimicry going on in those organizations. They talk the talk, but they're really not putting the money in where they should be. And I think that's a really big problem. And they're very, very keen to talk about funding the latest drug, the latest, MSED, the latest, but then prevention and public health, tiny. And that's number two. Number three is the ESMOs, the ASCOs, the big organizations which control a lot of the political narrative. I can't remember last time I saw proper sessions in these places with prevention and public health. It doesn't occur, okay? So, and it strikes me that this ought to be everyone's responsibility, and these are cross-cutting elements that should be part of these major conferences. If I had a magic wand, those are the three areas I'd wave over.
Thanks a lot. From my experience, like to add one point, it is probably also to make a little bit of a more self-critical appraisal of, how good are we in communicating the message to the policymaker in the first place. And then probably in the past, we sometimes thought we did it in a very brilliant way, when in reality, they thought what we were talking about is clear as mud. And we have to find better mechanisms of making sure that the message that we are delivering is really understood by the people who have to implement it. And I'm sure that there's sometimes a hesitation to ask questions because they think we assume they have to understand it the way we explain it, and they will not come back with questions. So we need, I think, a more face-to-face level discussion here, where we have also bilateral conversations, making sure it's really understood the way, because we don't have to convince everyone, but we have to implant the ideas in some influential people's head. And because people like to follow if they are good examples, we have to create these good examples and then hope for a domino effect that this will get other things going. Okay, when we see Clément on the screen, then that means it's time to wrap up. So back to you, Clément.
Thank you very much, and thanks to all for this very interesting webinar. There were other questions. We'll try to answer them even in writing. But I wanted to come back to one thing, and the latest part of the conversation. I was very impressed with all the different presentations. And I preach for my own stuff, but that's IARC being a multilateral organization, and we are, meaning to say that for us, IARC is actually governed by its governing council and scientific council, where sit the representative of our 30 participating states. And thus, and we know that in the past, certainly, that we've been struggling in putting prevention as part of the agenda, but we understand that this is what needs to be done right now. And the data that actually Richard gave us, it seems like it's not even a question, it's right now an urgency to actually make it happen. one of the things that we could do, and one of the things we're trying, and also as part of the IARC at 60 celebration, and I wanted to end on that we will be organizing a conference in Lyon from the 19th to the 21st of May 2026. And the whole topic of the conference, the idea of cancer research into action. And to make it very quick, because we have only 2 minutes, and just a kind of a teaser, but the whole idea of the conference is to go along the cancer research continuum, meaning that the first day it's more dedicated to this idea of the etiology component and understanding better through fundamental science what are the new causes, or the understanding better the causes of cancer. But the day two, it's more about what we discussed today. It's the idea that when we understand the causes of cancer, what do we know about the intervention that actually work on the field? And because we actually know that 40 to 50% of cancer are preventable, we actually know about the risk factors. So how do we make sure that people and policy can actually make that kind of a difference, and can actually have proper behavior that will protect them from cancer? But it's also the idea of secondary prevention, and what Partha actually explained us. For sure, what Professor Zeeb explained us as well, using MLs or ELs to actually get there and ensuring that information get translated, that scientific evidence get actually translated into things that people can understand and can act upon it. That's very important for us. So the day two, it's more about that translation of scientific evidence and using implementation research to actually make sure that at the end we do have concrete action on the ground. But then the day three of the conference, and the conference is actually co-organized with our governing council and especially with the French government. So actually the day three of the conference will be focusing on this idea of science for policy, which was one of the main concepts that actually IARC was created based on. No? And this is the idea of, again, we understand better the causes of cancer. We understand what works on the ground to actually prevent it. Then we give all that back to the policymakers to ensure that there will be a change. And I believe this is part of all the discussion we had together. So making sure we actually bridge the gap between the policy environment and the scientific one. So please do come for the conference that we will organize in Lyon. I do believe that we might have a few answers. We will have at least some ministers, and we'll be able to raise the profile of prevention and making them understand that, again, that this is not something to be discussed, that there is no other way than actually to invest more in terms of prevention to ensure that at the end we can have a clear impact and we can actually save the life of people. We launch a call for abstract for that conference, so you're more than welcome to actually submit your abstract as well and go through the conference website. But I will really stress the fact that you should come, and we should make sure that at the end we have a substantial amount of discussion that we can bring back to the policy environment and make sure that at the end they do understand the value of prevention, and for them and for the health system as a whole. So thank you again for the participation into the webinar. We're ending right on the clock at 3:30. I hope it was interesting. And for sure, we're more than welcome to get any kind of feedback and comments from you to ensure that at the end we can improve also in this webinar and make sure that we can continue having those kind of very interesting discussions that do make a difference at the end. So thanks a lot for all your participation. Thank you. Bye-bye.